VA is a 30-year-old female that came into the ER complaining of shortness of breath and chest pain, and she was afraid she was having an acute myocardial infarction, or better known as a heart attack. She stated she had had chest pains for the past 90 minutes, rating an 8 out of 10 on the pain scale, and being sharp and constant on the right side to the mid-back. The pain did not improve with lying down or other activities. She also mentioned that she returned home from a 13-hour business flight very recently. Pertinent past medical history to be noted is the history of her migraines with the multiple medications that she is currently prescribed for them. These medications do have a side effect and risk of causing deep vein thrombosis. She has protein S deficiency with a history of deep vein thrombosis 2 years prior. The protein S deficiency is a disorder of blood clotting. It increases the patient's risk to develop clots in the extremities or other abnormal places, and is influenced by other disorders. Deep vein thrombosis, abbreviated DVT, is simply a blood clot that is formed in the vein of your body. They are most common in the lower extremities. They can break off, and the loose clot in the blood is known as an embolus. The greatest risk in this process is if it travels to your lungs, thus developing a pulmonary embolism, abbreviated PE. This is most likely to happen when you have a clot in the thigh, over having one in the lower leg, or elsewhere in the body. Again, referring back to the patient's medical history, she did have leg surgery as a child due to trauma. Miss V smokes a pack of cigarettes a day and has occasional caffeine intake. She does frequently travel for business, with sometimes consisting of long flights and prolonged immobility. When examining the patient further, we did note that her respirations were 40 and labored, and she was exhibiting a bit of tachycardia with a heart rate of 105 in normal rhythm. Her BMI was normal and healthy at 23.1. She did have significant abnormalities upon examination of the chest, lungs, and muscular system, mainly in the extremities. Miss V displayed subnormal diaphragmatic excursion in her chest and lungs. This is apparent when there is an abnormal movement of a less than normal movement of the thoracic diaphragm. You can examine this by percussion of the back during inspiration and exhalation. Percussion is simply when you take one hand and lay it across the area to be percussed. Then with your opposite hand, you tap lightly on your flat hand with your fingers to hear sound. In this specific examination with percussion, it entails the process of the patient inhaling and exhaling while you percuss the intercostal space of the back. When you hear the sound become dull, that means you're at the bone and you mark that spot. Then you have the patient inhale and hold it while you percuss again to hear the dullness, and make another mark. Then you measure between the two markings. Normal results should be 3 to 5 centimeters in the examination of diaphragmatic excursion. Moving on to the extremities, upon examination it is noticed that the saphenous vein is visible in the left lower extremity, with multiple varicosities bilaterally, and both feet were cool to touch. The saphenous veins are the rather large veins located in the superficial posterior part of your leg. These findings, again, lead us to believe the patient has a blood clotting issue. Lab results were mostly normal with the exception of a slightly low hemoglobin and hematocrit and a high white blood count. If a chest x-ray were to be performed, it may reveal pleural effusion, dilation of pulmonary vessels, or an elevated diaphragm. A lower extremity venous duplex ultrasound was performed, and that revealed narrowing with incompressibility of the popliteal veins, which is consistent with bilateral DVTs. Other tests demonstrated further blood clotting conditions. We performed a VQ scan and a pulmonary angiography. The VQ scan showed perfusion defect at the right base, with abnormal perfusion and ventilation in the right lung. The pulmonary angiography determined abrupt arterial cutoff in the peripheral vessels of the right base as well. Between the two tests just discussed, the pulmonary angiography is the reference standard for determining if a patient has a PE. The angiography is a safe procedure where contrast dye is injected and 3 views of the lungs are obtained. 97% of the time, an accurate diagnosis of PE can be determined with this test, much like in this case with Miss B. The findings that we found are consistent with the diagnosis of PE and DVT. This concludes case study 9 on pulmonary thromboembolism. Thank you.